Good afternoon. My name is José Zuniga. I'm proud to welcome each of you to the opening of the 2020 90-90-90 Targets Update hosted by IAPAC in partnership with UNAIDS and ITPC. I'd like to acknowledge the support from Gilead Sciences and ViiV Healthcare for their generosity in making this session possible, and the IAS for including it in its program. I also, before we start, want to join voices with UNAIDS and IAPAC and ITPC in expressing our solidarity with all of you who are dealing with the difficulties of this time of the COVID pandemic, inclusive of making sure we have a continuity of HIV services globally. We stand in solidarity with you and understand the difficulties you're experiencing and are grateful you're joining us today. This AIDS 2020 virtual pre-conference is set to explore progress made and barriers impeding our ability to attain and surpass the UNAIDS 90-90-90 targets set in 2014, as well as the goal of achieving zero stigma and discrimination. Several of the 90-90-90 target update sessions to be broadcast over the next 2 days will feature both country and municipal progress. We'll address new metrics to monitor our progress past the deadline of 2020 for 90-90-90. And will give voice to key populations without whose active engagement we cannot succeed. But we start this update today with the 35,000-foot view of the global HIV response. I'm honored that Winnie Byanyima, the Executive Director of UNAIDS, joins us to share her insights about key issues related to HIV, COVID-19, and inequalities, all of which are significant areas of focus for UNAIDS. A staunch advocate of gender rights, democratic governance, and peace building, she is now leading the global HIV response, and her views are invaluable. Welcome, Winnie.
Thank you, Jose.
I don't know if you'd like to say a few words before we get into the session. Feel free.
Well, first, it's a great honor to be on your opening panel and to say that I so greatly admire the work of IAPAC. You are a leader, and you are so important for the next 10 years because we see now that HIV, new infections, mostly amongst key populations, particular groups in particular geographies, will need to drive down into key areas where we have high burdens and tackle the epidemic. And that will mean that we need organizations like yours that take us and lead us in those specific areas where we need to fight to make the difference. So I so value working with you, and I'm excited to be on this panel. Thank you so much.
Thank you very much to you. And we're honored to work with UNAIDS for so many years, but really excited about the directions you're taking, which are really important in order to address the epidemic beyond the clinical perspective. So with that, I'd like to start because one of your big issues that you have put on the table for UNAIDS and the global HIV community to tackle is that of inequality. And it's a major issue in relation to health outcomes, whether with regard to HIV, COVID-19, many other diseases, or life expectancy generally. With respect to HIV, we know that more men than women die from AIDS-related complications. Fewer men living with HIV are on treatment than women. Regarding COVID-19, there's not yet a clear pattern of incidence, but in most countries, the available data indicate that men have upwards of 50% more likelihood of mortality following diagnosis than women. And then life expectancy for men is also significantly less than for women almost everywhere in the world. Yet, if we flip the coin, there are many more examples of gender inequality's deleterious effects on health outcomes for women. Despite significant progress, women are still 5 times more likely to die in pregnancy, with 94% of all maternal deaths occurring in low and middle income countries. Around 500,000 women die from cervical cancer, 500,000 from breast cancer each year. And the majority of these deaths also occur in low and lower middle income countries where screening, prevention, and treatment are not widely existent, and where HPV vaccination needs to take hold. Depression is the most common mental health condition for women, and suicide leading cause of death for women under age 60. And we could go on and on with those statistics. So within that context, how do we balance gender inequality across the board without leaving any gender behind?
Thank you. Well, we need to unpack what is underneath, why there are different health outcomes for different groups, different individuals. Not all the difference will be because of gender inequalities. Of course, medical research shows us that genetics, anatomy, hormones make members of one sex more vulnerable to some diseases than others, but not everything is about biology. Gender as a social and economic construct, as something driven culturally, is something that also determines and shapes individuals' behaviors, shapes their identities and their roles in societies. And these can be linked to their health vulnerabilities. So we talk about gendered roles and gender norms and how they affect men and women's health differently. You may find that men die more from lung disease if they are coming from, say, mining jobs and jobs that expose them to a risk to their lungs. And you find that women in Africa might have a lot of diseases that come also with lungs because of smoke inhaling and cooking in kitchens, burning wood and biofuels. So gender norms, gender roles, gender identities also affect health outcomes. So we have the biology and we have the gender, the social and economic issues. Now, we also know that gender norms can go into formal laws. So you find that the biases that come in society because of the traditions also influence laws, policies, and practices. So again, you get an entrenchment of health inequalities because they move from the tradition, the informal setting into formal laws. So it breaks my heart that 6,000 in last year's report, our global report on AIDS, that 6,200 women and girls were getting infected every week, infected with HIV. For Africa alone, that's 5,100 young girls, adolescent girls and young women infected every week. And when you scratch deeper, you see that in sub-Saharan Africa, girls between the age of 15 and 19 are 4 times more vulnerable to HIV infection than boys of the same age. This is driven largely by gender norms, by social norms, that some of them justify sexual violence, they justify toxic masculinities, some of it is driven by structural inequalities such as lack of education for girls, equal opportunity to be in a safe school space. So we must tackle these. We must tackle the gender norms, the gender inequalities if we're going to close the gap for men and women in different socioeconomic settings. But it also works for gay men. It also works, the same argument can be made about people who inject drugs. This is about people whom society has put a value on, has criminalized, and so they face structural barriers, they face inequalities in health because of where society has placed them, because of the attitudes, the norms in the society. So across the board, we see men, women, and all those whose genders are indeterminate, like transgender, who are not, I'm not looking at it on a binary scale, I'm looking at across the scale, that people are affected differently, and that people of different sexual orientation also have society placing a value on them and denying them their right to health. So we must tackle these inequalities in health. I'm passionate about that.
I can tell. And that's amazing because obviously these inequalities are creating barriers to not only accessing the services that are required to achieve the successes we need to achieve to end AIDS as a public health threat by 2030, but they also represent a human rights violation if we don't address them. The reality, as you've said before, of large numbers of people, predominantly women, not having access to life-saving medications, life-saving interventions is a human rights violation in and of itself and needs to be addressed. And I'd like to stick to the topic of inequalities because as we look at COVID-19, we're seeing through the looking glass the inequalities put in very stark relief. When we analyze data for Black, Latino, Asian, and other minority ethnic groups, COVID-19 has revealed this deepening chasm between our espoused and our enacted values. In the United States, for example, the overall COVID-19 mortality rate for Black Americans is 2.3 times higher than for whites and Asians, and 2.2 times higher than for Latinos. And if we look in the United Kingdom, Black people are more than 4 times likely to die from COVID-19 than white people. And in Brazil, 55% of Black and mixed race patients die compared to 38% of white patients. Now, of course, we prefer nobody die, that we had a vaccine and treatment, but we don't. We live in this reality that we don't have options other than restrictive measures such as social distancing, hand washing, and masks. So I think it bears noting these disparities are pervasive and they're not isolated to any one geography. I mean, I think we see that beyond those examples I've just cited, and they're historically long-standing and systemic in nature, contributing to deep-seated racial health inequalities. So the current state of health among minority ethnic communities begs 2 questions that I'd like to ask you. And they're big questions, but I know you have the answers. So first, can health systems in which such disparities and inequalities exist truly be said to value human life equally? And since I can predict your answer meshes with what mine would be, what individual and collective actions must we take to meet the health and other needs of all people, not just the privileged few?
You know, Jose, this great American man, Dr. Tony Fauci, who's leading the coronavirus response in America, he was asked by lawmakers about one of the reasons why COVID was killing Americans of color, especially black people. And he just put it very simply, and he says, it's racism. He was right. He put it bluntly, simply, it's racism. It's not valuing people of certain races and giving privileged people of other races in health. This is what it's about, and in other rights. So we're seeing colliding epidemics, HIV and COVID-19, and both thrive on inequalities. They are existing in a very unequal and increasingly unequal world. And each of them shows us that not every human life is valued. They really make visible the fact that some lives are more valued than others. So whether you look at it in terms of the existing health disparities, the fact that these 2 epidemics find people already with other health disparities, that is one inequality. And then you also see the inequality in terms of accessing services for these 2 epidemics. I could come back to what I'm observing with coronavirus and the mobilization of huge resources to find a vaccine and treatments, and it's totally unprecedented. But this is not the first virus to hit us. Come on, this is not the first epidemic. Yeah, it's ravaged the whole world, but There have been others, but never to, but because it is attacking people whose lives are more valuable, rich people in rich countries of a white race, the money is found. Nothing against that, but you can really see the difference in value of human lives by looking at how different diseases are resourced. Anyway, coming back to health disparities, you also take it down to human rights. You take it down to prejudice, to stigma, to discrimination against sexual minorities, against sex workers, against drug users, migrants, people of color. This kind of discrimination, the stigma, these also constitute barriers, inequalities to health. So you see, you can layer it, you can see various layers of barriers that together combine to deny people their right, their human rights, including their right to health. Now, what we're seeing with COVID-19 and HIV, as they come together to devastate communities, we see that it is those on different axes of inequality that are most hit. So if you are a poor person, economic inequality, if you are a migrant, if you are a Black person, if you're a woman, if you combine various axes of inequality, you're going to be the most hit, because there will be violence, there will be stigma, or layers of stigma, there will be economic inequality, and so on. So we must address them. We cannot ever hope to create a world where we are prepared for epidemics unless we build more equal societies where everyone has access to healthcare, for example. So tackling the structural inequalities is part of building the health system of the future, the preparedness of the future. So we mustn't miss this opportunity of fighting for the right to health for all people, building health systems connected with social protection systems that work for all people, irrespective of race, of age, of ethnicity, and so on. And it's possible. We can do it, but we just need to use COVID as the opportunity to tackle old problems of inequalities.
It's a tough situation though, because, at the same time that we need to address these structural barriers and invest in all people, we find ourselves in a moment where we are attacked not just by a virus, but by its outcomes, which takes me to my last question for this session. And it really is around the resources we will need to not just recover as far as the disruptions in responses to various epidemics, but also in order to do some of the work that needs to be done, that you're really championing at UNAIDS. So the World Bank expects that local authorities will have about 15 to 25% less revenue from taxes, industry, tourism, or other sources of revenue over the next year, which would make it difficult to maintain the current trends of service delivery, let alone invest in improved health and social services for vulnerable and other key populations. That is, if countries choose to maintain their current resource allocation schemes, which I think we could agree that we prioritize the wrong things sometimes, military over health, and we can go on and on. And here in the US, the administration has announced it's withdrawing from WHO, a threat that brings with it the possibility of reduced funding in the midst of an emerging pandemic. And while we're making such significant progress, albeit not at the pace that we would like in relation to the HIV epidemic, and just very recently, the UK announced that the second largest donor announced that it's abolishing DFID, its foreign aid agency, in order to reorient its funding towards foreign policy objectives in lieu of development objectives. So, in light of this new environment of further financial constraint, or I would say retrenchment, how do we sustain our gains and continue to build upon them? And it's important for me because we need a very strong UNAIDS to lead the global HIV response. How does an agency such as UNAIDS, is reliant upon the largesse of nation states, continue to deliver on your mandate?
Good question. Let me start by looking at this from a global perspective and bring it down to UNAIDS. Globally, we know that the global economy is shrinking by close to 5%, negative growth of 5, and it's going to take even slower to build back. What has happened now, the disruption by corona, is really several times bigger than the disruption we last had, the global financial crisis. When you think about it, in terms of the destruction of the global economy and then the lives and the livelihoods, it's huge. But then we also see that to recover, we must solve the health issue, the virus, control the epidemic. For that one, we must first understand and move this in the fast track by taking a global whole of society approach to it. And this is where we come in as UNAIDS, advising, taking the best lessons we've learned from fighting HIV for 40 years. 40 years of the HIV movement, 25 years of UNAIDS. Fighting this tells us that you need a whole of society approach to get it right. That's important. And then the global collaboration. There's no room for this vaccine nationalism, countries cutting deals for themselves. We've got to use an open science method, pool the know-how, pool the technology, pool the intellectual property together so that we arrive at a vaccine or treatments fastest, we manufacture at scale in every region, and we treat everybody. So solving the health issue will require a global approach and a multi-sectoral whole of society approach. We campaign for this. But secondly, we have to address the issue of the structural issues of inequalities in health that we mentioned earlier. We have to tackle now the issue of people's right to health. Because, look, we have almost 43 countries in Africa that use user fees. It is not difficult to see that if you've got to pay some money in your pocket to visit a clinic, you will not go for a test. How? So first, we have to have health systems that work for everybody. And financing health systems is a big issue now that I see governments waking up to, but I don't know whether they are learning the lessons about building health systems that have preparedness built in for epidemics, as well as prevention built in, and are open and accessible to everybody. So the financing will take us into the whole area of how to raise the money. And let me tell you, there's something to learn from the global financial crisis. Hit by that crisis, the rich countries of the North realize that now they must take on their corporations and get them to pay their fair share of taxes. That's where we had the first time some corporate tax reform, some increased transparency, some increased revenues coming from companies to fund the rich countries. But no progress was made not enough progress for poor countries. So now we need a global corporate tax reform that will cut out all this tax dodging, close tax havens, and bring the revenues we need to build health, social protection, and invest in education in people's lives. This will only come when we work on the tax justice issue. Thirdly, we need to look at how we have seen health and the right health, the human rights approach, the fact that some people's health is compromised because they have their human rights, because they are underground, because you've criminalized them, because you've made it impossible for them to live differently from, say, the majority. So the issue of human rights is also now at the core, that we can have the money to resource, but we will have people always there, always being where the epidemic starts and grows, because they are on the margins. Their human rights are not respected. So we must make progress on the human rights agenda. And lastly, on financing, I think the world is not being fair here or even wise. There are countries that are today not able to keep two balls in the air, HIV and coronavirus, because they are so poor and heavily indebted. A little debt relief has been negotiated for like 6 months up to sometime early next year, but you're talking of a virus that's going to be with us for much longer. We need more long-term debt relief, debt cancellation, to free up space for countries to not to have to make a choice between dropping HIV services in order to fight corona. That's a false choice, but it's happening. And we have sent out an alert that if the services continue being disrupted, prevention and treatment services on the ground, that we could have an additional 500,000 AIDS-related deaths, including TB, by the end of the year, if the severe disruptions were to continue for another 6 months. So there's a serious and urgent need to support the poorest countries, to have the space to address two big health challenges, amongst others as well. The same countries are facing floods and droughts because of climate change, locusts, malaria. So a global approach to fighting the epidemic is needed, the pandemic, and resourcing is key, as you've said. Resourcing, enabling every country to have the money to fight. I hope I've answered your question. Perhaps I should add, for us at UNAIDS, we're focusing in 3 areas. 1, monitoring and defending services on the ground, the prevention, the testing, the treatment and care. Fighting and keeping governments focused there and helping. We're monitoring disruptions in supply chains and trying sometimes to see how to make sure supplies are there from one country to another and so on. So defense of the services. Monitoring and defending human rights in the context of these lockdowns is another area we are focusing on. I was fighting with my government about 19 gay men were arrested for really no reason. Well, after some weeks, months, they've finally been released, but they should never have been arrested. We're doing that across the world. Transgender people denied food because they have no identity card, sex workers being labeled that the cause of corona. So we're monitoring that situation and working with others to defend human rights and services, especially key populations. And thirdly, engaging on the global response, pushing hard for a vaccine that is going to be free at the point of use, technology that is shared, removing patent barriers, so that we arrive at solutions quickly and solutions for everybody. So we work in those areas of bringing lessons into global response and national responses and defending our constituency of people living with HIV and vulnerable to HIV.
Well, thank you, Winnie. Our time has expired for this panel, but I have to say that I can close my eyes and hear in your words spoken by the late Jonathan Mann, who was one of the founding members of our association back when I started my time with IAPAC. And It is so heartwarming and inspiring to know that we have someone at UNAIDS who is looking at the bigger picture and understands that this is not just about getting people tested, linked to care, treated, virally suppressed. It's bigger than that. People living with and affected by HIV/AIDS, as you know, are human beings with many needs and a right to live a life of not just good health, but with dignity. And so I thank you for spending some time with us in opening the 90-90-90 targets update. I thank you for also focusing on the very practical aspects of making sure that we do not have a disruption in the HIV response when we were making such tremendous progress over the last several years. And for also, of course, spearheading the efforts to make sure that the benefits of science are made available to all people, not just a privileged few. So thank you. I don't know if you'd like to say a few closing words. The floor is yours to close out the session.
Okay, so thank you very much, and thank IAPAC for what you do. And to repeat that it's so valuable and so important, especially for the next 10 years as we try to beat HIV/AIDS as a public health threat. And that thank you for this partnership with us at UNAIDS. We are only good because we have partners like yourselves working on the ground with us. And congratulations on this meeting. Thank you.
Thank you very much, Winnie. And thank you to all of you who are joining us for the 90-90-90 targets update. Please access the available sessions that we made public on the IAS website over the next 2 days as we discuss progress and challenges to achieving 90-90-90 within the context of the COVID-19 pandemic. Thank you very much. Thank you, Winnie. And we'll see you soon. Bye-bye.